You are lying on a dirt floor in 4000 BCE, somewhere in what is now southern Mesopotamia, and your fever has been climbing for 3 days. You can't eat. Your joints feel like they've been packed with hot sand. The people around you are doing everything they can, and what they're doing would strike most modern observers as either primitive superstition or, in a few cases, shockingly competent medicine. That gap between those two reactions is exactly where this story lives. Most people carry a version of the same assumption about ancient illness, that before germ theory, before antibiotics, before the ability to see what was actually killing people, ancient humans were essentially helpless, that they lit fires, chanted at the sky, and hoped. That medicine only became real medicine somewhere around the 19th century when science finally arrived to rescue us from millennia of darkness. The evidence does not support that. What the archaeological and anthropological record actually shows is a picture far more complicated and in some ways more sobering than the story of primitive ignorance we're comfortable telling. Ancient humans developed sophisticated pharmacological systems, performed surgical procedures that required genuine anatomical knowledge, and built public health infrastructure that some cities wouldn't match for another 2,000 years. At the same time, they embedded all of this inside belief systems that made no distinction between a pathogen and an angry deity. And that conflation wasn't stupidity. It was a logical response to a world where causation was genuinely invisible. Common belief? Ancient medicine was superstition with occasional lucky guesses. Actual reality? Ancient medicine was a functional hybrid system, part empirical observation, part spiritual framework, that worked often enough to be preserved, refined, and transmitted across generations. The superstition and the competence weren't separate tracks, they were the same track. That's not a minor distinction. It rewrites what we think we know about the history of human intelligence under pressure. Before getting into what ancient medicine actually looked like, it's worth sitting with why this question carries so much weight beyond historical curiosity. Every assumption we make about ancient healthcare shapes how we interpret the entire arc of human cognitive development. If ancient people were fumbling in the dark, waiting for science to rescue them, then knowledge is something that accumulated linearly, slowly, steadily, from nothing toward now. But if they were doing something more systematic, something that actually worked within the limits of what was observable, then the story of human intelligence looks different. It looks less like a climb out of ignorance and more like a series of very reasonable responses to genuinely difficult epistemic conditions. There's a direct consequence to getting this wrong. When we dismiss ancient medical systems as pre-scientific noise, we tend to overlook the empirical core that was often buried inside them. Ethnobotanists working in the 20th century documented hundreds of plant-based treatments used by indigenous populations that were later confirmed to have genuine pharmacological activity. Quinine, derived from cinchona bark, was used to treat fever in South America, long before European medicine had a concept for what malaria even was. Aspirin's active compound exists in willow bark, which ancient Egyptians, Greeks, and Assyrians all independently documented using for pain and fever reduction. These weren't accidents. They were the product of systematic, multi-generational observation, the same cognitive process as science running without the formal apparatus of science. Which means the real question isn't whether ancient humans dealt with sickness intelligently. It's why we ever assumed they didn't. And the answer to that question points directly at the assumption that has quietly distorted this entire field of history.
The assumption everyone gets wrong is that ancient medical systems were unified by belief in the supernatural, and that the supernatural component made everything else unreliable. The cleaner version of history sorts ancient healing into two bins, the mystical stuff that didn't work and the occasional herbal remedy that did, purely by accident. That framing is historically incoherent. Take the Ebers Papyrus. Written around 1550 BCE in Egypt, it's one of the oldest preserved medical documents in existence, and it contains 877 individual prescriptions. Some of them invoke gods, some of them are purely procedural, dosages, preparation methods, application instructions with no religious language whatsoever. The same document, written by the same culture in the same century, operating in both registers simultaneously. The Egyptian physicians who produced it weren't confused about what they were doing. They were applying different tools to different layers of the same problem. The spiritual framework addressed meaning and causation, while the pharmacological instructions addressed mechanism and outcome. That's not primitive thinking, that's triage. The Mesopotamian system was structured along similar lines. Babylonian medicine operated with two distinct practitioner roles: the Ashipu, who handled diagnosis through divination and ritual, and the Asu, who handled physical treatment through herbal compounds and wound care. These weren't competing systems, they ran in parallel, often on the same patient. Texts from the royal archives at Nineveh, dating to the 7th century BCE, record cases where both practitioners were called simultaneously, each doing their own work without apparent contradiction. What that parallel structure tells you is that ancient cultures weren't conflating magic and medicine out of ignorance. They were deliberately maintaining two explanatory systems because each one answered a question the other couldn't. The Ashipu answered why, the Asu answered what to do about it. Modern medicine still has that split, it just doesn't acknowledge it as cleanly.
The reason ancient humans developed any medical system at all, spiritual, empirical, or both, runs deeper than culture or tradition. It runs straight into evolutionary biology, and the mechanism there is more specific than most people expect. Humans are among the most socially dependent mammals on the planet. An injured or sick individual in a mobile foraging group is a collective liability. They consume resources, slow movement, and can't contribute to food acquisition or defense. The logical evolutionary outcome of that pressure should have been abandonment. In many animal species, it is. Chimpanzee groups have been observed leaving severely injured members behind, with minimal social response. And yet, the hominin fossil record shows something different, and it shows it surprisingly early. The case of Shanidar 1 is the one that reframes the whole question. Excavated from Shanidar Cave in northern Iraq by Ralph Selecki in the 1950s, this Neanderthal individual, who lived somewhere between 45,000 and 35,000 years ago, survived to an estimated age of 35 to 45, which was genuinely old for a Neanderthal. His skeleton shows a withered right arm that had been amputated or lost well before death, severe vision loss in the left eye, and severe arthritis throughout the body. He could not have fed himself. He could not have defended himself. He survived anyway, for years, which means his group fed him, protected him, and tolerated the cost of keeping him alive when he couldn't contribute. That's not sentiment, that's a behavioral pattern encoded deeply enough to persist across multiple individuals in the fossil record. Care behavior in response to sickness and injury appears to predate Homo sapiens by tens of thousands of years, which means the cognitive and social infrastructure for medical response, the impulse to intervene, to tend, to apply something and see what happens, wasn't invented by any civilization. It was already there, embedded in group behavior, long before anyone wrote it down. The question is what happened when that impulse met accumulated knowledge across generations.
What happened was a body of medical practice so detailed, so geographically widespread, and so pharmacologically coherent that it took modern researchers decades to stop being surprised by it. Start with surgery. The oldest confirmed surgical procedure in the archaeological record isn't bloodletting or amputation, it's trepanation, the deliberate cutting or drilling of a hole through the skull. And it wasn't rare. Trepan skulls have been found on every inhabited continent across sites spanning from 10,000 BCE in Neolithic France to pre-Columbian Peru to Iron Age Russia. At the site of Ensisheim in France, a skull dated to around 5100 BCE shows two trepanation holes, both with significant bone regrowth around the edges, meaning the patient survived both procedures, lived for years afterward, and the operations were performed without metal tools, anesthesia in any modern sense, or germ theory. That's not luck. Survival rates at some Neolithic sites ran as high as 70 to 80% based on bone regrowth evidence, which means practitioners were doing something right consistently enough to produce repeatable outcomes. The ethnopharmacological record is equally dense. The Kahun gynecological papyrus, dated to around 1800 BCE in Egypt, documents treatments for reproductive and gynecological conditions using compounds that include acacia, which modern research has confirmed contains lactic acid, a genuine spermicidal agent. This wasn't accidental inclusion. The compound was specifically recommended for contraceptive application. Somebody figured that out through observation, documented it, and passed it forward. In ancient India, the Sushruta Samhita, compiled between roughly 600 BCE and 400 CE, describes over 300 surgical procedures and 120 surgical instruments. Sushruta documented rhinoplasty, the surgical reconstruction of the nose, using a flap of skin from the forehead. The technique he described is close enough to modern reconstructive methods that it was still being referenced by European surgeons in the 18th century when they encountered it through Indian practitioners and brought it back as a new discovery. It wasn't new, it was 2,000 years old. The pattern that emerges across Mesopotamia, Egypt, India, China, and the pre-Columbian Americas isn't isolated ingenuity, it's parallel development. Different cultures, separated by thousands of miles, arriving at similar pharmacological and surgical conclusions through the same process: observation, application, outcome tracking, refinement. The Huangdi Neijing, compiled around 200 BCE, Chinese systematized acupuncture and herbal medicine within a theoretical framework of qi and balance that has no overlap with Western humoral theory. And yet both systems independently develop the concept of the body as a system of interacting components that could be pushed back toward equilibrium. Two completely different theoretical models, the same underlying intuition about how illness works. What neither system could do, what no ancient system could do, was see below the level of the observable. They could track which bark reduced fever. They couldn't know why. They could observe that certain wounds went bad in ways others didn't. They couldn't see the bacteria. And that gap between observable outcome and invisible mechanism is where the spiritual explanatory layer did its heaviest lifting, filling in the causation that the empirical layer couldn't reach. Which raises a question that the evidence answers in a direction most people don't expect.
The part that reorients everything is this. The most effective public health intervention in the ancient world had nothing to do with medicine at all. It was architecture. The Indus Valley Civilization, which flourished between roughly 2600 and 1900 BCE across what is now Pakistan and northwestern India, built cities with standardized brick drainage systems, covered sewers running beneath major streets, and individual household toilets connected to municipal waste channels. Mohenjo-Daro, one of the civilization's largest urban centers, had a sophisticated grid of drainage infrastructure that predates comparable Roman systems by nearly 2,000 years. The Great Bath at Mohenjo-Daro, a large watertight pool built with bitumen-sealed bricks, suggests organized, ritualized bathing as a civic practice at a scale that implies institutional sanitation awareness, not just personal hygiene preference. They didn't know what a pathogen was, but they built systems that controlled pathogen transmission with a precision that their contemporaries in Mesopotamia and Egypt, for all their pharmacological sophistication, didn't match at the urban infrastructure level. That's not a coincidence. It's not an accident. It's the whole point. The Indus Valley achievement indicates that ancient populations could arrive at genuinely effective public health solutions through observational logic alone, noticing that settlements with waste near water sources produced more sick people and engineering a response to that pattern without ever needing to name what was causing the problem. The mechanism was invisible, the consequence was observable, the intervention targeted the consequence. And honestly, that's a more unsettling thought than it first appears, because it means that effective public health doesn't strictly require germ theory. It requires accurate observation of outcomes and the institutional will to act on them. The Romans knew that water near latrines made people sick. They didn't know why. They built aqueducts anyway. The gap between knowing the cause and knowing the solution turns out to be much wider than we assume, and ancient engineers were already operating successfully in that gap 2 millennia before anyone closed it. What that leaves unexplained is why, if ancient populations could be this sophisticated about illness on an infrastructural level, so much of their individual medical practice remained entangled with spiritual causation frameworks that sometimes led them in genuinely harmful directions.
Ancient healers treated sickness with divided explanatory systems, one layer empirical, one layer spiritual, because the actual cause of disease was completely invisible to them. We treat sickness with a unified scientific framework, where the cause is, in theory, always findable. That's the specific difference. And yet, the behavioral patterns that ancient medical systems produced look, in several uncomfortable ways, almost identical to ours. Consider the placebo response. In ancient Egypt, the identity of the physician administering treatment was considered medically relevant. Senior temple physicians commanded higher therapeutic authority, and that authority was understood to affect outcomes. Modern randomized controlled trials confirm the same dynamic. Patients who believe their doctor is experienced and confident show measurably better recovery outcomes from identical treatments than patients who don't. The mechanism ancient Egyptians attributed to divine favor. The mechanism we now attribute to neurobiological pain modulation and immune response priming. The outcome is the same. The gap between those two explanations is the whole argument. Consider also how we handle the boundary between known and unknown causation. In Babylonian medicine, illnesses with no identifiable physical cause, no wound, no obvious infection, no dietary explanation, defaulted to spiritual diagnosis. The Ashipu stepped in precisely where the Asu ran out of answers. In modern clinical practice, conditions without identifiable organic cause are classified as psychosomatic, functional, or idiopathic, a Greek-derived term that translates with remarkable honesty to "we don't know." The category of unknown causation still exists. We've just replaced divine agency with Latin terminology. Ancient healers did X, we do Y. The gap between those two things is, in several specific cases, much narrower than the 4,000 years separating them would suggest. What persists across both systems, ancient and modern, is the same structural response to the same problem: a sick person, a practitioner with incomplete information, and the pressure to do something useful anyway. Ancient practitioners worked at the boundary of observable outcome and invisible mechanism. So do modern ones. The difference is that the boundary has moved, dramatically, genuinely, but it hasn't disappeared. The question that leaves open is whether we've inherited anything else from those first healers besides the problems they couldn't solve.
You are lying on a dirt floor in 4000 BCE, somewhere in what is now southern Mesopotamia, and your fever has been climbing for 3 days. Someone is coming to help you. What they bring, whether it's willow bark or a ritual incantation or a drainage system built 2 generations before you were born, is the product of something that started before writing, before cities, before any of the civilizations we use as landmarks for the beginning of organized thought. You came into this believing that ancient medicine was superstition, interrupted occasionally by lucky guesses. What the record actually shows is a system, imperfect, incomplete, frequently wrong about causation, but genuinely systematic, built by people who were doing exactly what we do, observing outcomes, refining responses, and filling the gap between what they could see and what they couldn't with the best explanatory framework available to them. The Neanderthal at Shanidar Cave was kept alive for years by people who had no theory of disease whatsoever. The physicians who wrote the Ebers Papyrus documented 877 prescriptions inside a culture that attributed illness to divine displeasure and still landed on acacia as a contraceptive compound with real pharmacological activity. The engineers at Mohenjo-Daro built covered sewers that controlled pathogen transmission 2 millennia before anyone could name a pathogen. Sushruta described a rhinoplasty technique that European surgeons rediscovered in the 18th century and called new. None of that is primitive. All of it is incomplete. And that distinction between primitive and incomplete is the one that actually matters, because incomplete is what every medical system in history has been, including the current one. The boundary between known and unknown causation has moved enormously. It has not closed. What ancient humans dealing with sickness actually tells you is that the intelligence was never the variable. The information was.